This conference will now be recorded.
Of OSP Lahore to please come over and start the meeting. Thank you.
Good morning, ladies and gentlemen. On the behalf of Ophthalmological Society of Pakistan Lahore branch, I welcome all the distinguished guests and participants of this meeting. On behalf of OSP, I welcome Dr. Amjad from all the way from Islamabad for guest talk, and we are thankful to Dr. Asma for hosting this meeting. I will highlight 2 or 3 things. First thing is that the residents who are participating in this competition this is not only a presentation, this is a competition. Those who are participating, the one who will win this competition will be taken to the grand clinical meeting that will be held at the Afro-Asian Conference of Ophthalmology that is going to be held in December 2022. So the winner is not just a winner in Children's Hospital clinical meeting, he will or she will compete in the grand clinical meeting and he will be appreciated over there. So keep it in mind. So your representation should be updated and you should be much more competitive than the usually you are doing for a routine presentation. One thing. Second thing is that the Ophthalmological Society of Pakistan has done a lot for residents in last few months and before too. The main thing for resident is that we have started the video and photography competition for the residents. It's every 3 months, but unfortunately in last competition I hardly find 1 or 2 residents competed. So I would request every institute, especially Children's Hospital, if your residents are here, so they can compete for that video and photographic competition, and that photographic competition winner will be awarded in the Grand Ophthalmological Society of Pakistan Lahore annual meeting. I mean, that will be coadjuvant with the Afro-Asian Conference. So that's one thing. Second, for resident grants and research grants are there, so anyone can apply for that grant, especially for residents, those who are presenting their research work in national and international conferences. And this is not only for presentation, it's also for the research. The last thing is that we have made a WhatsApp group to keep our residents updated regarding the OSP activities. So if any resident has any reservation or anything to discuss, he can discuss regarding his research projects and regarding his contribution in the scientific context. Moreover, we have added one more thing, that we have a biostatistician. So any resident who need any assistance in research, planning the research and methodology or anything, he can pursue for that a biostatistician. He is available 24/7 at the Ophthalmological Society of Pakistan Lahore office, or you can contact by email. You can visit him for any guidance and for any help in writing the article, starting the research or planning the research. Moreover, he is delivering lecture every week in different institutes on obviously biostats and medical writing. So that's one more additional thing. So these are few things that are more important for the resident. All else is that you know that Afro-Asian Congress is going to be held from 7 to 11 December. I will request all the residents, fellows, consultants to submit their abstract for the scientific program. Just visit the OSP website and go there, check the website of ACO and submit their scientific program. Because it's an international meeting, you will get good credentials after presenting in this meeting. Now I have a lot of more to talk, but I think we should start the clinical meeting now. So I will request Dr. Asma to conduct this meeting. Thank you so much.
Thank you very much, Dr. Khan, for giving the welcome address. We've been holding meetings in the Children's Hospital on behalf of OSP, but this meeting is special in the regard because now the Children's Hospital has been upgraded to the University of Child Health Sciences, and this is the first meeting of OSP which is being held after this institute has been converted to University of Child Health Sciences and obviously the Children's Hospital. So I think this puts more responsibility on our shoulders. As far as the research is concerned, we need to produce content which is up to the mark as a university. One thing to add here is that our participants are actually our medical officers because we don't have any level 4 trainee at the moment. So we are trained our medical officers who are working with us in our department for last few months. So they'll be presenting and they'll be competing for the presentations. Our first presentation is going to be Dr. Komal. She's Dr. Komal Virus and she has been working in our department for last few months. She's going to talk about an interesting case. So over to Dr. Komal.
Assalamualaikum everyone, I'm Dr. Komal Maris. Today I'm going to present an interesting case of a 1.6-year-old child with a red mark on face and a large eyeball. So first of all, the patient particulars. The patient, as already mentioned, was a 1.6-year-old female child, and he presented to us in emergency on May 25th, 2022. She was born on October the 23rd, 2020. Her chief complaints were that he has a red mark on the right side of the face, as well as she has an increase in the size of her right eyeball. So as you can see in the picture, on the right side, there is a red mark, which we call the port wine stain, whereas the right eyeball is a bit larger than the left one. So history of present illness was, there was photophobia and nearsightedness for a few months. It was associated with slight increase in the size of her right eyeball and whereas the photophobia and the nearsightedness was not associated with any diurnal changes. Her past history was that she had an episode of fever for 4 days, which was relieved by antipyretic. Along with that, there was a history of tonic-clonic fits. The patient was treated in emergency for the fits, and later on, she was referred to us when declared fit-free by the neurology department. So her birth and developmental history was normal. The ocular history was absolutely normal, no history of glasses, trauma, surgery, or laser. Her clinical examination done by the pediatrician was normal, except for the port wine stain. So coming to the most important part, that was of the eye examination, as we are the ophthalmologists. So the visual response of the right eye and the left eye were good. There was fixation and following present. The eyelid on the right side has a port wine stain, whereas that of the left was normal. Conjunctiva and the cornea of both the eyes were clear. The pupil were round, regular, and reactive. Lens were clear, whereas the extraocular movements of both the eyes were full. The ocular investigations carried out was, first of all, the intraocular pressure. That of the right eye was raised, and that was 30 and that of the left eye was within normal limits, that was 11. Axial length of the right eye was slightly increased, that was 21.65 millimeter, whereas that of the left eye was 20.91 millimeter, that is within the normal range. The corneal diameter of the right eye was also slightly increased, that was 12.5 millimeter, whereas that of the left eye was 11 millimeter. When the fundoscopy was done, it showed that the cup to disc ratio of the right eye was 0.4, whereas that of the left eye was within normal limits, that was 0.2. The macula of both the eyes was good and healthy, whereas the neuroretinal rim was within the normal ranges. The retinoscopy done of the right eye showed that there was a myopia of -3 diopters, whereas that of the left eye was emmetrope. So here are the pictures showing that we are measuring the IOP, the corneal diameter. So some of the investigations which were carried out were EEG, which showed no electrographic seizure activity. It was actually done in order to show that is there any sort of relation with the fits. The CT scan was also done because there was a history of fits, and it showed extraventricular CSF presence. There were focal hypodensity in the right posterior, parietal, and the temporal region, with few calcific foci in the right temporal region. So we discussed all these things with the radiologist, and the radiologist's point of view was that there is no prominent any leptomeningeal enhancement or pile angiomatosis. However, there was an enhancement of the CSF spaces, and there was slight enlargement of the choroid plexus and the diploic spaces. So these were the radiological findings, which can be seen in the CT. So on the basis of all this history, the examination, and the investigation, we came to 3 differential diagnoses. The first one was that the patient had a secondary glaucoma due to a systemic disease like a Sturge-Weber syndrome in this case. Whereas the second one was primary congenital glaucoma, and the third one was the secondary glaucoma due to any other eye disease. So the most conclusive one in this case, the diagnosis was Sturge-Weber syndrome, which was causing the raised IOP. So coming to the management, on the first visit, when the raised IOP was noted, we gave the patient the tablet AZM, which was given for 3 days along with the topical beta blocker. The pressure lowered to 28 from 30. On the second visit, the topical beta blocker eye drops were continued, and the pressure significantly improved to 25. 1 month later, we introduced a combination of eye drops in which there was a beta blocker that was given along with the carbonic anhydrase inhibitor for the long-term use. So actually, we also planned to do the EUA on the first visit, but it was not allowed by anesthesia department because of the history of fits. So we could not proceed with the EUA. So we had to do only the medical intervention. Only the medical treatment could have been done in this case. Now what we have done is that the patient is kept on the follow-up for her continuous follow-up for IOP and the CDR measurement, so that the track of the high pressure on the fixed-on vision could be noted, and we could just treat it. Along with that, her neurological assessment is also being done. So these are the references. So I would like to end my presentation with a quote of our founder, Quaid-e-Azam Muhammad Ali Jinnah. He said, "Education is a matter of life and death to our nation. The world is moving so fast that if you do not educate yourself, you will be not only completely left behind, but will be finished up." Thank you. Sir, actually the patient had a Sturge-Weber disease. The diagnosis was made, and we consulted. First of all, we consulted the anesthesia department, and they asked the patient had a history of tonic-clonic fits 4 days back before she presented to us. They didn't give us the permission to. They said that they would not undergo the anesthesia, so we couldn't undertake the EUA.
Actually, the treatment of glaucoma in children is surgical. There is no role of medical treatment. So I would recommend that you take a second opinion from any other anesthesia department.
Yes, sir.
It is in the welfare of the patient.
Yes, sir.
That if your anesthesia team is not able to do the patient operation,
Yeah.
any other institution can do it.
Yes, sir.
This is not a contraindication for anesthesia.
Yes, sir.
Right?
Thank you so much for your comment. I would like to add something that this is a case of secondary glaucoma due to Sturge-Weber syndrome. In Sturge-Weber syndrome, and we all know there is an extra scleral defect, which is causing delays in intraocular pressure. So what kind of surgery do you actually recommend in this kind of way, provided anesthesia?
Actually, how old is the child?
Sir, 1 year, 6 months.
1 year. So you prefer arteriotomy and some people, you have to give a try. At least you give a try, whether it succeeds or not. But my recommendation would be to have surgery as soon as.
Surgery successful, especially in the case of Sturge-Weber syndrome.
I have.
So you could add to my knowledge.
Actually, I have done operation with such there is a response. I do not remember how much, but there was a response. I have done operation with
Yes.
In my experience, people are very as compared to and in the mind perception, if you manage to get it, and in very few cases, you have to put forward a narrow. And so this intervention and within the I don't think I have to put
in a 1 year old child, what should be the IU?
Sir, it should be lower than 20.
Not lower than 12 or
12. Yeah.
See, 1 year old child has a normal weight of 10, 12.
Yes.
So 25, 23 is like 40 adult.
Yes, sir.
Double almost 3 times that of
Adult.
normal. So I don't think the disc will survive for a long time with this pressure.
Yes, sir.
Because it only decreases from 30 to 28 or 26.
Yes, yes, sir, 20.
25, 26 is.
Sir, after the combination eye drops was introduced, it reduced to 20. 20.
20
Yes.
is still not normal for 1 year old.
Oh, yeah.
So I would recommend that you should give a try of whatever surgery you want to do, but do it.
Yes, sir. Uh, yes, sir. So, yeah. Yes. Yes, sir.
Even for the document, when we were able to look at it, it was 0.4 in that area, because it was and 0.2 in the other area. And we were it was pretty heavy. If the patient is not controlled, then we might go for that, but I also mentioned as there are other fields kind of go the 4 days that where the target fields clearly see surgery mentioned is really very yes. The treatment of choice for dementia glaucoma is surgical and that is essentially practical dementia glaucoma. Thank you so very much.
Can you tell me, once again, you have been, what was the pressure on the last examination?
Sir, on the last examination, the pressure was 20. Yes, sir. Sir, on the other eye, it was within the normal limits, 12. 12. 12. Yeah.
And in this case, the pressure should be 12 or around.
Yes, sir.
A pressure more than that is doing damage.
Yes, sir.
Obviously, it's imperceptible.
Yes, sir.
And in the long run, that's going to add up.
Yes, sir.
And a lot of that.
Yes.
Second thing is, what you are using at the moment is either a beta blocker.
Yes, sir. And a carbonic anhydrase inhibitor. Yes, sir. Topical. No, sir. Oral. Oral was given for first 3 days and then it was stopped. Yes, sir.
But then it's still high pressure. So
Yes, sir.
you need to do something
Yeah.
more.
Yes, sir.
Be that more medical intensive treatment, or be that more very technical intervention and other testing,
Yes, sir.
or later, but the pressure must be brought to that.
Yes, sir.
It is high.
Yes, sir. Thank you, sir.
And there would start with, as I indicated, you are indicating provided practice level. What I would recommend is that you present the case in 2 minutes and then review of the literature in next.
Okay, sir.
The important studies which are related to your topic should be presented.
Yes, sir.
For improving our knowledge.
Yes, sir.
So, what do you sort of plan to do in examination in the anesthesia? What additional information you want to gather for you?
Sir,
Because I think you have done a very good work with the patient. You
Yes,
have
sir.
located the coronary diameter,
Yes, sir.
axial and the pressure. So that is sufficient.
Yes, sir.
I don't think there is any requirement for examination during anesthesia. We don't want to subject the patients for unnecessary anesthesia
Yes, sir.
problems. In my practice, in almost 99% of the patients, I do the examination with sedation.
Yes,
So
sir.
what do you use for sedation?
Says syrup sedate.
Good. So same. So that is sufficient to do a good examination.
Yes, sir.
Thank you.
Yes, sir. Thank you. Actually, we have to keep the timekeeping as well. Thank you, Dr. Komal. We usually use sedate syrup most of the times for examination in our OPDs because especially in a public sector hospital, 200 patients are coming and we cannot do EUAs for everyone. Yes, we do an EUA before proceeding for the surgery most of the times. So I already mentioned that we do not have any trainees at the moment, any fourth year trainees because of the induction staff like जी सर जी सर मैं हूँ डॉक्टर अहमद बैठे हैं डॉक्टर जेबुन साहब बैठी हैं
How do you administer the sedate? What is the dose of?
2.5.
How do you calculate the dose in a child? You see, every person in the OPD should know how much serum should be given in treatment. You see, okay, I will tell you. Under 6 months of age, it is 50 milligram per kilogram body weight. And above 1 year of age, it is 100 milligram per kilogram of body weight. So you have to remember it. So that you can work out in each patient how much issues could possibly you tell your assistants so that they can. Thank you.
Thank you so much, sir, for the valuable information. I would like to proceed to our next presenter, who is Dr. Madiha Minhas. She is also working as a... Ji, sir, please.
Very good. Given and very grand.
Mm-hmm.
My new position related to is very mostly here sent me a simple formula.
Mm-hmm.
He sent me here a business. So that's like clear that.
Mm-hmm.
And he says it is 6 months. He says out of that, what are those? You take 1 cc and mix it with 1 cc water and give it to the side to whom or to the friend or whatever it is. And then it is 1 year, it's 1.5, and next with 1.5 ml of that. 2-year-old, 2.5 ml plus 2.5 ml fluid, 5 years, 5 ml and 5 ml fluid. It says, put them somewhere in the corner, this is the left side and left side. But do remember that I do it mostly to do reflection in these children. And I need to put cyclopentolate as well.
जी जी
So
बिल्कुल.
practical tip I can share with you. I say to my assistant, okay, you go and do it in 20 hours. Put a drop of alkane in each eye.
जी जी.
And then put a drop of cyclopentolate, 1%. 3 times. Interval of 5 minutes. You are given the sedation. And towards the end of the conference, 5 minutes, the child will speak and people will die. Bring them back to the examination room. Put them on the couch and do your reflection quickly and do your fluoroscopy quickly. I must say, I've never tried checking their intraocular pressure. For 2 reasons. I don't have a photometer and I feel very much sure photometer on that. So this much I can say with you, the dosage as far as the practice. And I have written it down and put it under my put it on my so every time I have it, I just refresh myself on it. Very good.
Thank you. Thank you so much, sir. This is actually the dosage which we are actually using, क्योंकि वो जो हमें बताया जाता है कि वो यही है कि वो 6 महीने का आधा ढक्कन और उसके साथ दूध पिला दो, फिर 1 ढक्कन, वो तो उसकी और जेनेरिक फॉर्म आ गई है, because you know, just to make it simplest possible. Anyways, thank you so much for the input, and I was introducing my next speaker, who is Dr. Madiha Minhas, and she's going to talk about a case of grouping of eyelids and restricted eye movements. Dr. Madiha Minhas, please come.
Assalamualaikum everyone. My name is Dr. Madiha, and today I am going to present you a very interesting case of 10 years old boy who presented to us with complaint of drooping of eyelid, and also he was complaining of restricted eye movement. This is the profile of my patient, and his name is Ahmed, and he was, as I mentioned earlier, 10 years old boy and admitted through OPD. And he was resident of Kasur, and we admitted him on 3rd August 2022. His presenting complaint was he was complaining of drooping of eyelid, and also he was complaining of severe neck pain due to his bad posture, and also he was unable to move his eyes in all directions. This is the picture of patient, and we have already taken the consent from patient to show his picture on this platform. In his history of presenting complaint, he was in usual state of health 4 years back when he started developing drooping of eyelid, which was gradual in onset and also progressive in nature, and also associated with restricted eye movement in all directions. Also, it was accompanied with the gritty feeling in both eyes and watery discharge from eyes. In his systemic inquiry was unremarkable. And his ocular history was he was being treated for papillary conjunctivitis in his last multiple visits because he was complaining of itching and grittiness in both eye, and he was being treated with mild steroid and artificial tears. But later on, he developed a steroid-induced glaucoma, and for which we prescribed him anti-glaucoma drugs. In his clinical examination, a systemic clinical examination, we referred the patient to a pediatrician and who advised some tests like MRI and ECG, which was non-significant. And so in his eye examination, his visual acuity was reduced markedly bilaterally 6/60 in both eye, and his bilateral lid creases were absent due to severe ptosis, and his cornea was slightly hazy, but conjunctiva was clear, pupil was round, reactive, and regular. His lens was clear bilaterally, and bilateral fundal view was hazy due to hazy view of cornea. A retinoscopy was not possible because there was hazy view. And as I mentioned earlier, his extraocular movement was restricted in all gazes. And his intraocular pressure was being controlled with anti-glaucoma drugs. And his right eye pressure was 16 and 14 in left eye. And in his ptosis assessment, MRD distance was -3, Bell phenomena was absent bilaterally, and palpebral fissure height was reduced markedly to 2 mm. And his lid creases were absent bilaterally. Fatigability was also not present there. Marcus Ganjar was also absent. Elevator function was 1 mm. This is the corneal ulceration, lid ulceration, and this picture we have taken before surgery. And preoperatively, this is picture of checking the intraocular pressure. And on the basis of our history examination and investigation, we reached to 4 differentials, which was chronic progressive external ophthalmoplegia, and myasthenia gravis, myopathy, and congenital ptosis. All 3, myasthenia gravis, myopathy, and congenital ptosis, was being ruled out as there was no muscle weakness or gait disturbance, and also there was no sign of any fatigability, and also patient developed his symptom 4 years ago. Therefore, our concluded diagnosis was chronic progressive external ophthalmoplegia, for which we treated patient with minimal sling surgery. And after the surgery, patient visual acuity was significantly improved, and he is happy now. And this is post-operative picture of patient, and this is picture after 2 days of his surgery. Thank you so much. This is all.
What was that? Yeah, तो आपने वेल्स फिनोमिना मेंशन किया वेल्स नेगेटिव तो वेल्स नेगेटिव हो तो कोशिश सर्जरी में क्या तो उसमें हमने मिनिमम सिंक के इंटरव्यू एक्सेस हुआ 1 millimeter नहीं है और आप पूरी करेक्शन करेंगे तो एक्सपोजर पे तो ये आपने माइसीनिया से जुड़ा किया नहीं और हाँ हिस्ट्री में predictability और variable well managed. Excellent.
Thank you so very much, as we are running short of time as well, and we have to keep timekeeping also. So we'll move to our next presenter, who's Dr. Anusha, and she's going to talk about a child of 9 years age and with poor vision in both the eyes. Over to Dr. Anusha, please.
Assalamu alaikum. I am Dr. Anusha Zabeen, and I'm going to present you a case of 9-year-old child who had poor vision due to dislocated lenses. My patient was a 9-year-old male who came to us through OPD on 29 July 2022 with the presenting complaints of gradual decrease in vision for past 2 months. My patient was in usual state of health when he started developing decrease of near vision for almost 2 months, which was associated with multiple falls and poor school record, and it was not associated with any diplopia, pain, or any diurnal changes. In ocular history, my patient had no previous history of using glasses, laser, surgery, or any medication. On ocular examination, visual acuity of my patient was reduced to counting fingers in both the eyes. Adnexa was normal, cornea was clear, both the lenses were inferotemporally subluxated, anterior chamber of the patient was normal, extraocular movements were normal and full, alignment was orthophoric, intraocular pressure was normal, fundi was normal, axial length of patient was in the right eye was 24 millimeter, while that of the left eye was 23 millimeter. It was markedly increased, slightly increased in right eye. On general physical examination, we noticed some features of Marfan syndrome, just like high arched palate, thin long limbs, and wrist and thumb sign positive. So we consulted pediatrician to rule out Marfan syndrome, and they advised us following investigations, which showed echocardiogram, chest X-ray, and skeletal survey was normal, and we could not perform genetic studies for Marfan syndrome as it was not available in our hospital at the time. On the basis of history, investigation, and examination, we concluded on to 4 differential diagnoses: Marfan syndrome, homocystinuria, Ehlers-Danlos syndrome, and ectopia lentis, which was the case. There were 2 management options in this case. Trial of glasses was given, but it was not successful. So we proceeded on to lensectomy with anterior vitrectomy. After the procedure, there was significant improvement in visual acuity from counting fingers to 6/24 with +10 diopter glasses. Following references were used. I would like to end my presentation on the quote of Muhammad Ali Jinnah, who emphasized on hard working by saying, "Work, work, and work, and we are bound to success." Thank you.
March syndrome आता है
जी sir?
March syndrome.
नहीं sir.
Marfan syndrome में आमतौर पे condition is upwards and forward. So in most other conditions, it is down.
Inferotemporally.
तीनों में बोलो। आपको मोबाइल कैमरे भी बड़े अच्छे आ गए, आपके कैमरे से भी ये काम कर रहे हैं, तो आप इसको पब्लिश कर, क्योंकि आज से बगैर फोटोग्राफ के कोई एक्सेप्ट नहीं कर पाते।
सर उसकी फोटोग्राफ ली थी, लेकिन मेरे वाले कैमरे में वो जो सब लग्जरी लेंस था वो शो नहीं आ रहा। जी जी, नजर नहीं आ रहा।
बच्चों की हमारे पास अपनी पेरेंट्स की तो ये प्रॉब्लम आ रही है। ये सारी चीजें इससे ना ही लाकोमा का नहीं इफेक्ट है, लेकिन कोशिश जो मेरी है वो बच्चे को ज्यादा है बस तो उसका दस प्लस जो बीच में ऐसे थोड़ा सा ये फर्क है।
ये मास्टानी जो है वो क्लिनिकली होता है, इसको डिफरेंशिएट कर देता है। मास्टन में फिंगर दे आर लॉन्ग एंड
थिन लेंस
और ये मास्टानी में स्टडी एंड शॉर्ट।
जी सर।
क्लिनिकली इसको पूरा पता कर और रेंडम ये कि व्हाट वी हैव टू हैव विद तो बहुत अच्छा है, लेकिन नहीं मिल रही है पूरी आ जाती है। लेकिन कोशिश करें कहीं ना कहीं से आपको आप लोगों को देना है फाइट।
ठीक सर।
यह आपने हिम्मत करनी है कि युवा नौ यूनिवर्सिटी तो ये जो दाएं बाएं वाले हैं दूसरे ये जवाब देने वाले इन्होंने हमसे अपील करनी है कि आप आपके पास में सोचते होने चाहिए और आप इन लोगों को हेल्प आउट करें।
I have to be good presentation first of all. Appreciate that. The only thing you should improve if you are going to next level of presentation that your slide should have more than 6 lines. It should be more, not more than 6. It should be 3
Okay,
or
sir.
4 lines on one side. You should
Okay,
just every time you look at your slide. You should know the slide either for written with you or it should be on your podium. So these things you should need to improve.
Okay, sir. I will work on it.
So regarding the presentation, which patient has some vexation, we did run that meeting, everyone does it. Does it stand for something to get from patient? Why few points for a subluxation and then retinal surgery? If the subluxation is static and it's like that, try not to do lumpectomy in any situation. Believe me, because 90% of them will end up retinal defect. It's very easy to go and improve and do the lumpectomy, and that's what I tell you. But 90% of them will go with regular detachment sooner or later. Why? Because these are pathological items. These are not normal items. They don't behave normally till after the death. Second, most of the lumpectomy is done from the liver approach. That is not advisable. That harms more and pronounced more towards the retinal detachment rather than if you go to the plasma. So this is regarding the surgical procedure, why you shouldn't do it. The surgeon should know why you shouldn't do this. To do it everyone knows. That may be little. But now you define exactly use the bar. Why you shouldn't do it? If it is lying, take it less. It is lying, take it something, take it less. The best thing is check whether it is a fatigue line in normal people, then you should have to reflect whatever situation. It is the rule, and it is must be there. If it is a fatigue crystalline line and in a normal people, it is fatigue, then you should retract it. No indications of anxiety, whatever situation it is. If it is not present in the normal people and whether appreciated in the widely colored people, then you should check whether you are getting more than 50% ACT kind, then if that patient is ACT question. So these are the basic rules that should be followed for this. No hurry for the therapy. For ACT, it will be 669 with right. For fatigue, if it's normal people, whatever the substitution is, if it is not more than 50%, it's a very kind normal. So you should refract first, not going for lumpectomy. If going for lumpectomy, only in very few situations should be done to the plasma, and that patient should have a complete vitrectomy, not only anterior vitrectomy. Complete vitrectomy with these serious laser. Otherwise, you are going to go to decline in the retinal detachment, private detachment, and whatnot. So these are the two things not to do.
Thank you.
Thank you so very much for this valuable discussion. It is very important thing which I've read somewhere. First, the surgeon learns how to operate, then he learns when to operate, and finally he learns when not to operate. Thank you so much, sir. I would like to take this opportunity कि अगर हम अब उस patient को आपके पास refer कर दें, because actually we are all gathered here to learn something for the betterment of our patients. हमारा aim तो यही है ना. तो हाँ जी, कितना फायदा हम दे सकते हैं.
ठीक है, अगर उसका हो गया डेफिनेशन शुड बी रेफर्ड बड़ा इजीली उसको अंडर दिए वी कैन डू 360.
So we have laser as well.
अगर उसको पूरी ट्रैकिंग की जरूरत है वो करनी चाहिए. प्रैक्टिस करना इशू नहीं, आसान है, लेकिन ये देखना है कि हम उससे कितनी चीजों को प्रिवेंट कर सकते हैं. तो ये कोई इशू नहीं आता, मर्जी पे
ठीक है सर.
Because homocysteine usually also found in the DD of ectopia lentis. So my suggestion, because as far as frequency of ectopia lentis is concerned, after the marker, the homocysteine urea is the main cause of ectopia lentis. So and it is treatable also.
जी सर वो usually
Treatable conditions should always be ruled out. To prevent the progression of the systemic manifestation.
जी sir. Thank you so very much, sir. We'll proceed to our next presenter. She's Dr. Sazim. Sir कुछ कहना आपने? हाँ, sir. So you agree with Dr. Khakan? Thank you. Okay, we'll proceed with our next presenter, who's Dr. Sazim. She's going to talk about a 14-year-old child with a conjunctival mass. Over to Dr. Sazim.
Assalamu alaikum. I'm Dr. Aqsa Azim, and the case that I'm going to be presenting today is about a 14-year-old child who presented to us with a conjunctival mass. So initially, I would like to tell you something about my case, that it is not something that we see every day. It was quite unique when we first encountered it in our OPD. We weren't able to make a prompt diagnosis or render it a name. But as the case has slowly unwinded, we have done some investigations, some procedures, and we have drawn some conclusions. Some are yet to be made, and that will be the topic of my presentation. So my patient is a 14-year-old female who presented to us in OPD on 15 June 2022. So this is what we are dealing with. This is the conjunctival mass, and this is the verrucous nevus present on her face. Her chief complaints were a mass protruding from her left eye, which was painful and causing loss of vision. As moving on to the history of her present illness, the mass under the upper eyelid was present since birth, but initially it was almost the size of a pea and was not associated with any kind of pain. It has only grown in size for over the last 4 months, and it is now about the size of a small lemon, you can say. Also, there's a venous malformation or verrucous nevus present on the left side of her face and neck, and it is present since birth. Moving on to the past medical and surgical history of a patient. The patient has been using topical steroid creams for some time on her face for the betterment of that nevus. There was no improvement. Dermabrasion of the patient for the nevus was done at Mew Hospital 2 years back, but as you can see that none of this has been very helpful for her. Her birth and development history were normal. However, there are some mild behavioral changes present in her. Her general physical examination was done by a pediatrician, and it appeared to be normal except for the lesion for the nevus present on her face and the mass. Her ocular history is insignificant. There's no history of glasses, laser trauma, surgery, or medication. Her ocular examination for the right eye, as you can see, is quite normal. Her vision is 6/6. Adnexa is normal. Pupil is round, reactive, and regular. Whereas in her left eye, the vision is PL plus minus. And the adnexa of the left eye shows a pink soft conjunctival mass prolapsing from the upper eyelid. The cornea is opaque. There's a mass prolapsing from the left eye. Retinoscopy of the right eye is normal. Emmetrope. In the left eye, we weren't able to, there was no view, so we weren't able to perform a retinoscopy or fundoscopy. The IOP of the right eye was normal, that was 18, and in the left eye, there was no detected. This is the condition of her cornea. Moving on to the investigation that we have done for this patient, CT brain and orbit of the patient was done. That revealed some cerebral atrophic changes, and that were kind of consistent with Sturge-Weber syndrome. MRI brain that showed that the patient had left preseptal hemangioma. Echocardiography was indicated when the patient has one episode of sinus arrhythmia prior to the surgery, but it was insignificant. We have made some differential diagnoses, which are conjunctival cyst, dermoid, hemangioma, orbital teratoma, and lipoma. Management of the patient. This is important regarding to this case. As the mass was vascular, we could not have done an excision without cutting off its blood supply. As we are ophthalmologists, we needed the help of some interventional radiologists at this point. Dr. Saima and Dr. Adil were kind enough to intervene, and they did an angiography which revealed that the mass had a direct supply from the ophthalmic artery. So before embolization, an informed consent had to be taken, and that was taken at the moment, and we did the embolization of the ophthalmic artery. Now, just for our knowledge, as we are ophthalmologists, I'm just giving you briefly the route they used for the percutaneous technique. They achieved through the right femoral artery to the right iliac, to the aorta, left common carotid, internal carotid, and eventually into the ophthalmic artery.
Now, after the intervention done by the radiologist, we were able to do an excision of that mass, and we did it in our OT about 3 to 4 days back, and the mass was resected and has been sent for biopsy, and the final diagnosis would be made on the report of the biopsy. This is the pre-op pictures. This is the mass, and this is after the surgery. Thank you so much. I would like to end my presentation with a quote from our beloved leader: "There is no power on earth that can undo Pakistan." Thank you so much.
The eye is seen negative, plus minus,
Ji.
and cosmetically it is not accepted. So what else can you do for this? You see, the first priority is to preserve the DNA, but if DNA is not a consideration, then cosmetic appearance is a consideration.
Yes.
So what would you like to do for this? What is your plan? Good. So different cosmetic appearance जो है ना वो हर एज के एक इम्पोर्टेंट कंसिडरेशन ये चीजें कॉस्मेटिक फीमेल में ज्यादा इम्पोर्टेंट हो जाए तो आप अपना प्लान बनाए कि इन्फ्लेशन या इन्वेस्टिगेशन करना है So you try to improve the cosmetic appearance.
उसका वो फर्स्ट पेज लगा दो.
I would appreciate investigations, healing and radiology or histopathology. So this is what is required in such cases. Histopathology report comes expected.
So usually. इसमें से तकरीबन 70 ml का ब्लड लॉस था और स्पेशली इसके अंदर बिकॉज न्यूरो इंटरवेंशनिस्ट जो है हमारे पास शी वाज वेरी मच कंसर्न्ड बिकॉज दिस ट्यूमर वाज हैविंग डायरेक्ट सप्लाई फ्रॉम ऑप्थेल्मिक तो शी डिस्कस विद मी आल्सो एंड आल्सो विद द पेरेंट कि जी क्योंकि बच्चे को बिहेवियर इश्यूज भी हैं और पेरेंट्स वर रियली वेरी वेरी कंसर्न्ड कि किसी 4 महीने में सर अकॉर्डिंग टू द पेशेंट
So you have to rule out the carbon gas grow color. So general systemic examination will.
So वो तो उसका 2-3 दफा सर वो तो उसका 2 दफा हुआ है पीड्स डिपार्टमेंट में लैदा हुआ है बिकॉज ऑफ बिहेवियर इश्यूज हमने उसको बिहेवियरल साइंसेज वाला जो डेवलपमेंटल पीडियाट्रिक्स के लैदा से दोबारा से सेस करवाया फिर एनेस्थीसिया उसको क्योंकि 3 दफा दिया जा चुका है एक दफा इंटरवेंशनिस्ट ने दिया फिर हम लोगों ने लैदा से दिया उसको सेस करवाया तो उसके अंदर कोई भी ऐसी उन्हें चीज नहीं लगी है ठीक सर जी सर
उसमें हम वो भी और कौन कौन से प्राइमरी साइट है ये भी हमारे नहीं होना चाहिए बच्चों में ये सबसे ज्यादा कॉमन होती है यहाँ से मैटर वैसी बात
है लिवर बोन ल्यूकीमिया से ज्यादातर मेट्स आते हैं लिम्फोमास Thank you so very much. These were the 4 case presentations from our hospital, Children's Hospital Lahore. And now we'll move to our international speaker who's online and we'll play her talk. She's going to talk about cases of complex cases of management of complex cases of pediatric glaucoma. We'll play her recorded talk and she's online. You can take down the questions and we'll ask her questions afterwards. Thank you so very much.
One more thing I'd like to add. Ophthalmologist at Manchester Royal Eye Hospital. I want to thank you, Dr. Due to the time restriction, quickly skim through the indications. Due to the time restrictions, I will quickly skim through the indications, different devices available. I will share with you the surgical steps we adapt for the tube implants and the post management. These implants are indicated in complex situations with previous failed glaucoma surgeries, secondary glaucomas like aphakia, uveitis after the corneal transplants. They're also indicated in severe ocular surface disease where conjunctiva is already compromised for primary trabeculectomies. The devices can be non-weld or weld. The non-weld ones rely on the margins formed by the fibrous capsule around the plate. The blood is formed around the implant, which creates the space for drainage. The valve implants, however, depend on the intraocular pressure. There is a certain pressure where the valve opens and drains the fluid into the reservoir. These are some of the commonly used implants available in the market. We commonly use bar width implant, which is non-valve, and we use a larger, the implant with a larger plate, 350 millimeter size. There are procedure-specific complications, which are suprachoroidal hemorrhage, overfiltration resulting in hypotony, shallow anterior chamber, cataracts, and hypotenuse maculopathy. There is a risk of exposure of tube. Malpositioning of tube can result in local corneal decompensation, and the tube can cause mechanical restriction and diplopia. I'll go through the surgical steps. The first step is adequate exposure with 7 or silk traction suture. The implants are placed in the supratemporal quadrant, and the traction suture is placed in corneal stroma supratemporally, which gives very good and adequate exposure for the rest of the procedure as shown. The next step is conjunctival peritomy, which is again supratemporal. In 3 clock hours, we start from the limbus, and due to relieving incisions, care is taken to clear the tenoid from the sclera also, and to make sure we have a good dissection posteriorly. The next step is to apply antifibrotic mitomycin C for 3 minutes, followed by copious irrigation. The edges of the conjunctiva are held with the clamp to avoid any exposure of these antifibrotic with the edges, which can impair healing in future. You can see the mitomycin C is applied quite posteriorly to the site where the reservoir and the tube plate will sit. The tube is then placed under the, it's skilled under the recti muscle. The lateral rectus muscle is hooked with a squint hook, and the edge of the tube plate, which we call as a ring, is tucked under the lateral rectus muscle. These recti muscles enter the plate in place and help us to avoid any posterior migration of the tube plate. You can see the superior rectus is hooked, and the other edge of the plate is tucked under the superior rectus. These plates are stitched with 8 or 9 nylon suture. There are small eyelets in the plate, and the sutures are threaded through the eyelet and secured. As this is a non-valved implant, we control the outflow by threading the tube lumen with a supramid trio. The other options to thread it is 40 or 30 proline, which are colored. One end of the supramid is threaded in the tube lumen, and the other edge is secured in a succinon pocket in infratemporal fornix. Post-op, if the intraocular pressure is not optimally controlled in 2 to 3 months' time, this suture can be pulled out. We have secured the plate. So now we are preparing to place the tube in anterior chamber through a scleral tunnel. The scleral tunnel is made 1.5 millimeter away from the limbus. It's a 3-step tunnel, like a phaco incision, and the tube is threaded through the tunnel into the anterior chamber. Care is taken when the tube is cut. The end of the tube should be beveled, so it threads itself through the scleral tunnel. The longer tube poses the risk of constant rubbing the lens, and the small tube poses the risk of once the tube is threaded through the scleral tunnel into the anterior chamber, care is taken to make sure the port is not leaky. If it's leaky, we can place some sutures around on the outer side of the tunnel. The final step here is to place a box suture to enter the tube in place to avoid any migration in out of the tube. The box suture is done with 9 or silk and is very important. As we have tied the tube from the one of the final steps now, the tube is in place in anterior chamber. We have to cover the tube with something. We commonly use tetoplast, which is processed pericardium. Cut the tetoplast to appropriate size, and it covers the tube nicely. Secure the tetoplast in place with 9 or nylon sutures at both ends. This gives quite a long-term cover and avoid exposure in future. Once the tetoplast has been stitched, the final step is meticulous closing of the conjunctiva. The conjunctival edges should be closed edge to edge. The edges are closed with a slip knot, and we make sure we have some episclera in the knot so the slip knot doesn't slip it to avoid any retraction of conjunctiva. The conjunctival radial incisions are stitched with the running suture, and perilimbal conjunctiva is closed with the metal suture. The surgical time is quite long. It takes about 90 minutes to 2 hours to complete the whole case, but every stitch is worth to prevent any late or early complications. The valve implants are primed before they are placed and secured. To summarize, the course of management is intense steroids and topical antibiotics for 4 weeks at least. We do give oral prednisolone in UVA. To summarize, these devices are useful in management of complex glaucoma. However, meticulous technique is required to prevent early post-op complications as hypotony and shallow anterior chamber. There's lots and lots of stitching during the surgery, which is all worth it, and it prevents any migration, especially in the pediatric age group. As we know, the pediatric eyeballs are the going eyeball, and so we make sure the tube, the plates are well placed, well secured, and well covered with tetoplast. Thank you very much for.
Thank you very much, Dr. Rehana Sadia. I would also like to add that Dr. Kenneth Lee, whose videos she has used because he is a glaucoma consultant in Royal Eye Hospital in Manchester. He's also online with us. So you can ask and they'll answer. Both of them are online with us. Thank you so much and welcome, Dr. Kenneth, to our meeting. I hope you can hear me.
Yes, thank you.
Thank you. Any questions?
सर माइक में दोबारा बोलें.
what are his results in trabeculectomy instead of trabeculectomy?
Okay, Dr. Kenneth, can you hear me? We have a question regarding doing trabeculectomy in a patient with Sturge-Weber syndrome.
Okay, so for Sturge-Weber, I tend to avoid trabeculectomies for them. I have tended to do tubes to avoid the vascularity of the tissue and the sclera, and also to avoid the sort of hypotony. I find that they don't do very well with trabeculectomies. They tend to risk of hypotony and suprachoroidal hemorrhages with trabeculectomy. So I tend to use a glaucoma tube for my Sturge-Weber patients.
Thank you so much. Any other question? The mic click there.
Where is the youngest or the earliest age you do shunt surgery?
So Dr. Kenneth, we have a question. What is the youngest age of performing glaucoma drainage device surgery?
So the youngest I've done is about probably 2 or 3 months. So they put it on someone who's had congenital glaucoma, who's got a trab, and I've tried needling that, and then it didn't work. So we did a tube for them in about, and they were about 3 months old, and she's doing very well. She's after tube surgery, drops in pressures of 10. So
thank you. There's one more thing I would like to ask, and that is that can you tell us anything, any condition where you would recommend not to do a drainage device surgery or not to do a tube surgery for a patient with congenital glaucoma?
So I think if they have very shallow anterior chamber or not a lot of space in the anterior chamber, then there's not really much that you can't really do. There's no space to insert the tube, so you have to be careful about that. If there's no space, because you can end up putting the lens or the tube get blocked, or you have higher risk of corneal decompensation. So you might then want to consider doing something else instead. I always so that's the main thing. And also, if I don't have a good view into the anterior chamber, then I would sort of try and avoid doing a tube, because then I can't see where I'm placing a tube when what's going through. So I might do something else as a temporizing measure to put the pressure down, and then do a tube later. But largely most of my practices I put a tube in. So.
Thank you. Any other question? Any other question? Thank you so much. One more question, please. Ji, Dr. Kamal.
Is there any role of surgery in glaucoma and capitis ratio is 0.8 in adults?
Okay, Dr. Kenneth, we have a question not related to this talk, but in adults with a capitis ratio of 0.8, what do you recommend? Is there a role of any drainage device procedure at their age? Adult patient, 0.8 issue.
So in an older patient, you say?
He's around 30 years of age, more than 30 years.
All right, so that I would what the intraocular pressure, what the visual fields looks like, and so if they've got a full visual field, and the pressures are controlled with drops, then we may not need to. If they're not controlled with drops, then you may need to consider doing glaucoma filtration surgery. So that may be a trabeculectomy first of all for someone of that age group, or if they've had a trabeculectomy before, then you may need to do a tube. My decision on whether to proceed with any type of surgery is all dependent on whether they've got any visual field change or progression, or if they have signs of progression. So if they have no signs of progression and the pressures are controlled, then I wouldn't do anything. If the pressures are not controlled or they have signs of progression, then obviously I would do something, and that would be, and then whether that's a tube or one of these movements, then it depends on what the patient like from what the coloring is like, what the eyes like, what the visual function is, and what and things. So therefore, I take all those into account before making a decision whether to tube or not.
Thank you so very much. Thank you so much, Dr. Sadia and Dr. Kenneth, for joining us online and enlightening us with your talk. Our next presenter is our national speaker, Dr. Mohammad Amjad. He is working as a consultant ophthalmologist and vitreoretina specialist at Al Shifa Hospital, Rawalpindi. And I'm so grateful to him that he joined us for this talk. And he was the first person to arrive today in this auditorium. Thank you so much. Over to Dr. Amjad.
Thank you very much, Dr. Asma, for inviting me for this talk. And Khakan Sahab, thank you very much for your kind words earlier. Khakan Sahab is not listening to me. Anyways, my name is Mohammad Amjad. I'm one of the retina surgeons in Al Shifa Eye Trust Hospital in Rawalpindi. I've done my training in the UK with fellowships in both adult and pediatric VR. No financial disclosures. डॉक्टर असमा ने मुझे 3-4 दफा मैसेज किया कि मेरी टॉक 7 मिनट से ज्यादा नहीं होनी चाहिए, तो व्हाट आई हैव डन इज के मैंने जितने इमेजेस हो सकते थे वो मैंने लगाए ताकि वी कैन गो थ्रू देम वेरी क्विकली. So what I'm going to talk about is the retinal findings and complication long term basis के ऊपर जो patients हैं जिनको ROP जो premature बच्चे. And what I have done is I've categorized them into two categories. There are so many kids जिनको untreated या type 1 ROP नहीं होती and they regress. तो उन बच्चों के अंदर what are the retinal findings? And secondly, in the other category, I'm going to be talking about the long-term issues we face in the babies who undergo the treatments. So in the untreated ROP babies, these are the babies जो treatment criteria को meet नहीं करते. And if we see there are quite good papers जिनमें इन babies को up to the age of 40 years इनको follow किया गया. And they have majority of these babies when they grow up they have retinal findings starting from the lattice changes from the retinal hole and even retinal detachments. अगर आप इनके numbers देखें and the burden of the disease or the treatment burden later on in बच्चों के अंदर, the lattice-like changes are up to 50% in these babies. Retinal detachment is about 40%. So we cannot just discharge these babies. What we used to do in England is in बच्चों को discharge पे भी the advice was to see their opticians regularly. And when they grow up, they always been told to attend the eye hospital immediately if they develop any flashes or floaters. I'm going to show you a few cases. This is the case one, untreated ROP, now 27 years old male. He was at 30 weeks ex-prem. In the right eye के अंदर, if you see in the right eye, the blue circle is basically showing the retinal detachment. It's a rhegmatogenous retinal detachment. Or previously, if you see closely, जो red circles हैं, ये previously diagnosed retinal holes हैं, जिनको laser हो चुका है. And they actually these patients they are on a lifelong risk for developing their retinal detachment. और इसको अगर आप closely देखें तो vascular avascular जो zone था when they were babies, they do develop some lattice-like changes. And this is another case, now 10 years old baby who was 30 weeks ex-prem. ये हमारे पास present किए and he had a big detachment, और ये detachment का border अगर आप देखें it's coming up all the way into the arcades, and this red line shows the area of the blood vessels were ghost vessels की तरह की appearance थी. We did the buckle. This is the edge of the buckle. Or after the buckle, the detachment was successful. Or बाद में fluorescein के, if we do we did the fluorescein, and there is a big area of ischemia in the periphery, and this ischemic area जो है ये long term they can lead to the issues. अब मैं second category में जाऊंगा, the babies who got treated. First of all, the babies who had the laser treatment for their ROP. ये मेरा last year एक patient था, she's a 29 years old female who was 30 weeks ex-prem. She presented with a loss of vision in the eye. This is this photograph after the retinal detachment surgery. Basically, she had the treatment with the laser, and she developed a total retinal detachment. और इसके breaks जो थे सारे, it was all around almost 180 degrees at the edge of the where the laser was done. So she underwent a PPV and oil, and later on oil removal. Another very interesting case, extremely premature, 27-weeker, baby had a post laser TRD. So if you look at the photograph, जब बच्चा present किया हमारे पास on the follow-up, जब detachment हो चुकी थी on the referral, we asked for the previous images, and if you look at the images, laser में यहाँ पे there were skip areas जहाँ पे laser नहीं हुआ था, और इसकी वजह से the patient developed later on retinal detachment. So हमारे unit के अंदर it was the practice was that when we do the laser, we do the pre-laser and the post-laser red cams. So in case if we miss any areas, we redo those areas. अगले group के अंदर I'm going to discuss the treated ROP babies, the babies who had the anti-VEGF. With the anti-VEGF, what I'm going to discuss is the complications we get with the injection, the technique of the injection. Or second group, I'm going to be talking about the problem, the issues we get with the anti-VEGF, basically the drug. जो ROP injection, ROP babies को injections लगाते हैं, there is a very nice protocol, safer ROP. If you read the guidelines, I think we should all follow the guidelines. We have moved to 4 millimeter needle, a small needle. लेकिन जो पुरानी जितनी भी studies देखें, Rainbow या Beat ROP, the needle size was pretty big. It's just to avoid the retinal touch or retinal trauma during the injection. The second important thing was the site of injection, the distance from the limbus, 0.75 to 1.0 millimeter. Interestingly, Beat ROP study and there was 4 millimeters, so they were going through the retina. And the one of the very important thing is that these patient needs a very regular follow-up. And now, because of the increasing number of babies having the anti-VEGF instead of having the laser, हमारे पास present कर रहे हैं late detachments की वजह से. And now we in the UK, we were जितने बच्चे हैं उनको what we do is at the age of 60 to 65 week post menstrual age जो है, we would do the examination under EUA, and we, if needed, we'll do a fluorescein angiography as well. और अगर उसमें area of avascular, we'll do the laser. Secondly, coming to the issues we get with the drug itself. The picture on the left side, type 1 ROP, we had the injection. After the injection, developed a very severe fibrotic changes, pre-papillary area के अंदर. Second patient के अंदर, again, there was the type 1 ROP, had the laser done, circumferential इसको, retinal detachment हुई है. Both patients, they underwent the vitrectomy. हो क्या रहा है इसमें? Same what happens in the diabetic patients. हम लोग जब वेजएफ दे रहे हैं तो उससे सॉरी जब एंटी वेजएफ दे रहे हैं तो वेजएफ ड्राइव उसकी कम हो रही है, तो जब वो ड्राइव कम हो रही है तो फाइब्रोटिक ग्रोथ फैक्टर जो है दैट गोज अप, और इन बच्चों के अंदर देन दे गो इनटू द सिकेट्रिशियल डिजीज और इनके इश्यूज आते हैं। अनदर केस, ये 60 वीक के ऊपर इसको फॉलो अप किया गया है, और when we did the fluorescein there was a big area of ischemia, so do the laser, discharge the patient back to the pediatric ophthalmologist. Sabse last, so these were the patients who get referred to us at the Great Ormond Street for the vitrectomy. Before I go into this and show you some cases, for the vitrectomy, there are a few things we need to understand. खास तौर पे बच्चे जो है, we need to understand the anatomy. The baby's anatomy of the eye is very different from the adult. And secondly, we need to understand the tractional detachments जो होती हैं. We need to understand the pathology. It's very different from the diabetic detachments जो हम रोज देखते हैं clinics में. So what is the difference in the anatomy? Anatomy के अंदर बच्चे जो हैं up to the age of 2, the eye is growing. The posterior segment is only 20% of the adult posterior segment. So if you see, it's not the human eye. I've just downloaded this from the Google, but it shows very nicely that the posterior segment is very small. The issue is that इसके अंदर pars plana vitrectomy करना it's pretty difficult. क्योंकि हमने lens touch होना ही होना है. So the main issue is what we struggle is the short size of the posterior segment. Now coming to the pathology, इसके अंदर along the arcade traction के अलावा what we get is the AP tractions, anterior posterior tractions. Or the anterior posterior tractions are mainly along the base, the vitreous base. Or अगर if the lens is that big, ये तो normal adult की picture है, लेकिन if the size of the lens is very big, we can't address the disease at the anterior edge of the retina. So vitrectomy करने के लिए we have to do the lensectomy, otherwise we won't be able to do the good vitrectomy. Again, the problem with the lensectomy is, as a pediatric ophthalmologist, I'm sure Dr. Asma or your team would agree with me, the risk of glaucoma is at least 6 times more. जिन बच्चों के अंदर lensectomy हो रही है, the glaucoma risk is much more. The other issue is एक retinal issue है, and then we are creating another problem along with the glaucoma is the amblyopia. So what is the solution? The solution is कि किसी तरीके से हम अगर बचा सकें लेंस को और विट्रेक्टमी कर सकें, और the solution is the lens sparing and endoscopic vitrectomy. जब हम माइक्रोस्कोप पे बैठ के बायोम से या रीसाइड से when we are doing the vitrectomy in the adults, we can see up to the probably equator, or and then we need to indent sclera indent करके ताकि हमें anterior vitreous नजर आए. लेकिन बच्चों के अंदर if the lens is very big, you can't do the indentation. And so what do we do with the endoscope? The benefit is that we can address any pathology which is anterior. And this is another, I mean, similarly, this is the real picture. Through the biome, we can only see probably up to the arcades or probably up to the equator. Lekin the same patient के अंदर जब हमने disease देखी है, with the endoscope, we can see and we can address and we can do the vitrectomy. और ये जितने anterior posterior tractional bands हैं, इनको we can easily cut those. Same thing, ये anterior ये वाले bands हैं जिनको हमने address करना. So what we do, Great Ormond Street में Dr. Asma भी आई हुई थी, I'm sure you can recognize the theater. We are operating through the microscope, and we are operating and we're using the endoscopic view as well at the same time. ठीक है, दोनों it's very difficult. We get disoriented. तो कभी माइक्रोस्कोप से हमें ये चीजें कंफर्म करनी पड़ती हैं whether we are doing the right thing कि नहीं. मेरी वीडियो चलेगा तो. So basically this is the endoscopic view. Endoscope left हाथ में पकड़ी हुई है और we make sure what is up and what is down. आगे 4 minutes पे 4:25 to 4:35 पे 4 मिनट 4:25 पे. Sorry, I had few issues on the PowerPoint, so बस छोड़ दो इधर. ये अंदर, this is the lens. These are the bands which we see with the endoscope probe. The camera is covered, we can see it and we can do the vitrectomy. The surgical time with this endoscope is probably 15 minutes. वापस slide पे चलिए. So हमारा 3 years का data from Great Ormond Street from 2014 to 15. If you see, what we have done is compared our lens sparing vitrectomy with the standard technique to vitrectomy here. And we were achieving a much more higher rate of reattachments, and primary lensectomy was 0%. I think that's a very important slide. When to refer to a VR surgeon. In the UK, the guidelines, pediatric ophthalmologist को Great Ormond Street से ये थी कि refer the patient as soon as they see the traction. And the earliest sign for the traction was the straightening of the blood vessel. एक दफा traction start होगी, dragging of the macula हो गया, those babies can't achieve a good vision. Second, अगर किसी को vitreous hemorrhage अभी dragging नहीं भी vitreous hemorrhage हो गया, then risk of amblyopia, then we would like to see these babies as well and proceed with the vitrectomy. So we, as the technology and the skills are improving, in Park especially, we are facing the third epidemic wave. We'll be seeing much more babies. These babies need a regular eye examination, lot of workload, probably lifelong inka risk hai. So that is very important thing to remember. Consider 60 weeks later. हर बच्चा जो anti-VEGF layer है, this is the new protocols now we are following. The fourth point is very important, effective communication. I think as a pediatric ophthalmologist, we need to liaison with the NICU team and the VR team as well. So LGH के साथ Dr. Asma, probably. And early referral for the lens sparing endoscopic vitrectomy as well. Abhi tak in last 5 months since I've been here in Pakistan, मैंने unfortunately कम से कम 7-8 बच्चे देखे हैं जो कि stage 5 में हैं, where we can't do anything. So early referral is what makes a big difference. And the other thing is it's very emotionally draining as well to face these parents. Unfortunately, to have a baby with the sight impairment. We had a message मुझे आया था, that is, this is a desperate situation. This is, if you read the last paragraph, this is from a parent. So a lot of emotional issues. So I think we as a team should try to see these babies earlier or इनको refer किया जा सके treatment के लिए. Any questions in the future? These are my emails and my WhatsApp number as well. Thank you very much. Sir, ਤੁਸੀਂ ਰਹਿਣ ਦੇ. Sorry, say again, sir.
आप कितने मरीजों का मुआयना करते हो या उनको लेजर करते हो आरोपी है एनेस्थीसिया के साथ या बगैर एनेस्थीसिया के?
Sir, in the UK, we were doing with the in Pakistan. I'm not doing the laser. My pediatric ophthalmologist team is doing the laser, and that has, I think they are doing under sedation. में कर रहे हैं, मैंने सुना. I don't know the answer. But in the UK, we were doing with the NICU के जो consultants थे, they were doing the deep sedation as well as the GA. My preference, if you ask me, I think it's the GA is the best thing. क्योंकि ये बच्चे जब स्क्वेयर इंडेंट कर रहे हैं, लेजर कर रहे हैं, they go into the aphyxia या हार्ट रेट इनका नीचे चला जाता है तो
इससे ज्यादा मुश्किल एग्जामिनेशन मैंने जिंदगी में किसी रेटिनल डिजीज का नहीं देखा, ठीक है। और उस एग्जामिनेशन को अगर आप समझते हो कि पकड़ के कर सकते हो तो यू आर नॉट गोइंग, यू वुडंट बी एबल टू डू इन दैट पहली बात। जो 90% है 99% पाकिस्तान में ऐसे ही हो रहा है। आप इसे पकड़ के करते हो आप इंडेंट कैसे करते हो? लाइनिंग बिटवीन पीपल विद इंडस्ट्री टू मेम्ब्रेन और 1.5 मिलीमीटर या 70 में से आप देखते क्या हो, ठीक है, पहली बात। और दूसरी बात, अगर आप उस पर एनेस्थीसिया नहीं करते तो आप लेजर कैसे करते? तो मेरा मैं रनिंग टीम में नहीं, मैं आपको थोड़ी सी प्रिवेंशन बता दूं, रनिंग टीम में नहीं है जो आरओपी को लीड कर रही है, लेकिन आई हैव वेरी सीरियस कंसर्न अबाउट injecting the infrared without anesthesia, in doing the laser without anesthesia, doing the ROP examination without anesthesia. That is done about 90% of the ROP patients in this city. ये बड़ा very cruel कि आप किसी के बच्चे को इंजेक्शन लगा रहे हो 2 महीने या 1 महीने को बगैर एनेस्थीसिया के और उसको लेजर कर, मैं ROP के लेजर को करना I need 15 to 20 minutes.
सर मनु घंटा लगता है सर it's very painful, yes.
और मेरे लिए आदमी के बच्चे को लेजर करने में 15 से 20 मिनिमम हाफ आवर भी लग जाता है अंडर एनेस्थीसिया। भाई दोनों के लोग कैसे करते हैं, कैसे कर सकते हो आप लेजर बगैर एनेस्थीसिया के और बगैर इंडेंटेशन के? इसकी नॉट ए रिपोर्ट दी Sorry.
I have done fellowship in Australia, and there was a routine that ROP patients were examined without anesthesia in NICU, and for later they would go, and that was the routine in Australia.
Sir, a routine examination is without GA, definitely. Like in any treatment, when the patient comes to the VR, they're not coming for, they are at the end stage. So they would need, I would completely agree. Yes.
How you are going to indent the retina in a case. वो जो भी करते हैं, I know everyone. जो ऑस्ट्रेलिया में करते हैं, जो फ्रांस में करते हैं, I have seen many of them and I've got used many of them and know many. But it's not practically true. आप अपने बच्चे को चाहो, could you like? No. They get silos और नीले पीले हुए होते और आप लगे हुए उसको देखने। और मैं बताऊं, मैंने पहले कहा, it's the most difficult examination, most difficult. I
agree, sir.
We should train our fellows to see the normal retina in these cases. मेरी बातें बहुत लगती हैं, लेकिन मैं आपको सच बताऊं, हर बच्चा शहर में 30 हफ्ते से पहले पैदा हो रहा है, उससे इंफ्रारेड एंटीबैक्टीरियल लग रहा है, चाहे मरीज चाहे वो ना चाहे। मेरे पास 10 पेशेंट एविडेंस है रेड एंड इमेजेस, उनको आरओपी नहीं है, उसके इमेजेस पहले लिए रेड क्या करते हैं और उसको कंसल्टेंट ने एडवाइस किया हुआ है 3 इंजेक्शन कि आज ही लगाओ अभी। मैडम विल यू बिलीव आपके पास एक बच्चा आया था जो यूके से मामा थी, वो बेचारी दूसरी कोविड में उसके 2 ट्विंस पैदा हुए, दोनों ट्विंस को दुनिया में कहीं आरोपी नहीं थी, वो सिर्फ गलती से बेचारे 3 हफ्ते से पहले पैदा हो गए दुनिया में। आज उन दोनों के रेड के एक्टिविटी लिए आप सोचो मैं दुनिया के डेंगू मतलब वो दिन में कुछ 10 वैक्सीन आरोपी करती है। मैं इससे बचा नहीं हु हैज डायग्नोस्ड, मैं ये नहीं बता रही है मेरे नोट से, मैंने कहा मुझे किसी नोट से रेफर हुआ। आप सोच सकते हो कि मैं महीने में 2 मरीज ऐसे देखता हूँ जिनको या लग चुका होता है उस इंजेक्शन या लगने वाला होता है, तो उसको आरोपी नाम की या फॉर गॉड सेक ट्राई टू डायग्नोज आरोपी। अगर आप इस तरह डायग्नोज करोगे, मतलब ये कानून बन गया है कि जो अखबार में बच्चे ने 3 हफ्ते से पहले होना है और उसके बाद थोड़े से पैसे, थोड़े से भी ज्यादा पैसे उसने इंट्राविट्रियल लगवाना है। ऑप्थेल्मोलॉजिस्ट देख लिया और वाली फिगर है, हाँ मैंने देख लिया, इसको भी टीका लगा। और जिनको और सुनते जाए जो लेजर जिस तरह लगी है, आई हैव सीन अ पेशेंट उसका बेटा पैदा हो, उसको लेजर आप सुन सकते 3 स्पॉट वो तेरे में 600 माइक्रोन मीटर से मैकुला, ये आरोपी के लेजर है। यार मसला ये है कि किसी डॉक्टर का नाम लेना मकसद नहीं है, इसको बुरा भला कहना नहीं है। द पीपल हु आर ड्राइविंग द फोर्स ऑफ आरोपी टू लाहौर और इन पंजाब और पाकिस्तान एटलीस्ट दे शुड ट्रेन द फेलोज to do the inter-spectrum examination। अगर वो नहीं है, please buy the red cap। दुनिया में सबसे आसान तरीका आरोपी को डायग्नोज, अगर आपको इंटरेस्ट नहीं करनी आती आप तो रेड कैप लो। रेड कैप महंगा नहीं ले सकते, इंडियन लो, इंडियन नहीं ले सकते। हैंड एंड डिजिटल कैमरे आते हैं 5,000 20,000 के मोबाइल, वो लो, कैमरों अपनी पुलिस पर बैठो, आरोपी लग रही है या नहीं है उसको करो। अपनी उस इंटरेक्ट स्किल जो आपने कभी की ही नहीं, उसकी स्किल पे आरोपी डायग्नोज करके पीछे लगाना पर गॉड सेक, मैं इसमें बड़े मेरे एक्सपीरियंस है और मैं इस पे बिलीव मी मुझे नहीं अच्छा लगता ये बातें बोलना, लेकिन किसी बिकॉज वो माँ बाप को नहीं पता, वो कहीं जा नहीं सकते, एक महीने के बच्चे को लेके और फिर से ट्राई। एक बात दूसरी वजह से आपकी जॉब में से मुझे दो चीजें सीखी है। जो बच्चा आपने दिखाया कि उसकी कैरेक्टर डिटैचमेंट थी और लेजर हुई तो वो एरिया मिस हुआ,
यस
ठीक है। अब मुझे ये बताओ जिससे वो लेजर थी, हाँ दैट आइडियल केस, अगर ये बच्चा सिमुलेशन में होता, वो प्रॉपर रेटिनल सर्जरी या प्रॉपर रिएक्शन में होता, वो इसको इंडेंट करके करता, यू कुड हैव हाफ मिलियन बेटर रिजल्ट देन दिस वन। ये भी बगैर इंडेंट करके देखो ना, आर्केड के पास
सर इस केस में भी ये जो अब 30 साल की लड़की हो गई है, दिस इज नॉट अ गुड लेजर एज वेल।
वो हमने सामने बताया कि आरोपी की सर्जरी का मेन ऑब्जेक्टिव ये है कि आप रेटिनल आरोपी की सर्जरी है एक ब्रेक बना दो रेटिना में डिटेक्टिव लाइट whatever the situation will be detective light, only you have to address two vectors, which is vertical and horizontal vectors को काटना और वो करना। तीसरी बात एंडोस्कोपी विट्रेक्टोमी, that's a very good tool for myopia cornea or for lens sparing vitrectomy. I totally agree with you, but the issue with endoscopic vitrectomy is just a one deep. You don't know where is your retina. So it's very difficult to attain this skill, and you were lucky you had endoscopic. I know you may know Sabara is deals with more of the endoscopic with the corneal opacity. So this endoscopic I think is a very good tool, but until they don't incorporate the 3D unit, it's very dangerous and very difficult to follow. Thank you so much for your talk.
Thank you very much, sir.
Very correct. वो मेरे को बच्चा होता है उनको डेवलपमेंट की तैयारी नहीं है, पेरेंट्स आर ओनली फॉर वन और आई एग्री विद यू फुली,
मैं इस सवाल का भी जवाब दूं, मुझे बेसिकली इसलिए कि हमारे ऑप्थेल्मोलॉजिस्ट के पास सवाल का जवाब नहीं है। इसका सिंपल सा जवाब है कि आरोपी को बच्चे को इंक्यूबेट नहीं करना हो, देयर इज नो इंक्यूबेशन। मुझे एनेस्थेटिस्ट ने कहा आई हैव रिटन द कंसेंट अगेंस्ट हिम, मुझे उसने कहा कि जी मैं इसको नहीं एनेस्थीसिया दे सकता क्योंकि इसकी
चेस्ट खराब है, आप सारे ऑप्थेल्मोलॉजिस्ट को क्लीन को नहीं अदा कर रहे हैं। ये बात ध्यान में रखिएगा, दुनिया में कोई कॉन्ट्राइंडिकेशन नहीं है नसीब देने के लिए चेस्ट खराब हो। When you are doing it on sevoflurane and on the mask, any kid in the world can be take the sevoflurane with the mask, even with the laryngeal mask, even he has a worse care. मैंने कल शौकत खाना में 18 यूए किए हैं, बिलीव करें आज तक पिछले 12 साल में आज तक एक यूए पोस्टपोन नहीं हुआ। मैडम सोचे एक यूए पोस्टपोन नहीं हुआ, क्योंकि उनका चेक से वैल्यू पोस्टपोन करेगा उसको रीजन देनी पड़ेगी ना प्रॉपर। एक यूए पोस्ट और एलजीएस में मेरे 8 यूए में से 6 पोस्टपोन हुए हो गए, कैसे खराब। और अगर मैं कहता हूँ कि ये कानून है कि आपने सीवो पे मास्क रखो, इंक्यूबेट तो करना नहीं है, तो कैसे आप लिख के दे दे बच्चा मर गया तो आपके लिए। प्लीज मैं आपको सच बताऊं, इसको सीधो पे 3 बार 8 पे आप दें, उतनी देर में एग्जामिनेशन करें, मार्क्स उठा रहे ऑक्सीजन पे ब्रीथ कर रहा हूं जाते हैं। हां रिटायर्ड हो गए हम, लेकिन मैं सिर्फ पहले के लिए कह रहा हूं कि कोई कंट्रा इंडिकेशन नहीं है। चेस्ट खराब होना भी सीओ फ्लोराइड पे मार्क्स बच्चे आरओपी के 90% ऑफ द टाइम यू कैन डू देख रहे हैं। मैडम मतलब ये है कि हमारा ऑप्थेल्मोलॉजी भी आर्ग्यू नहीं कर सकता ना।
मैंने इस आर्टिकल में लिखा, मैं 2 हफ्ते पहले यहाँ आया था सिविल हॉस्पिटल में, गलती का ऑपरेशन रेमेडी है 3-4 दिन से। तो 2-3 चीजें मैंने गलती की थी, एनेस्थीसी क्या है वो बात कर रही है। यहाँ पे आके ना वैसे डिप्लोमेट है एनेस्थीसिया वाले के डॉक्टर ने कहा कि यहाँ पे ना पूरी मैथड साइड सारा काम होता है, यहाँ पे छोटे बच्चों को ध्यान करते हैं सारा। ये जो कान की बात की नेट करने की, वो ऐसे विदाउट वो करते हैं। मैंने इस आर्टिकल लिखा कि मेरी बात से मैं बताया नहीं मालूम हुसैन के होने से बड़ी तकलीफ होती है। आपके जो बेटे जा रहे थे दुनिया से सुबह नाम, तो आपने फरमाया कि बड़े गम दे गया, आपने अम्मा को फरमाया कि जन्नत में जरूर है। तो औलाद की जो टेंशन बड़ी अजीब सी है, बच्चों को यहाँ से एनजीओ किया जाता है। छोटे बच्चे का मैंने कहा कांटेक्ट को डिस्कस की स्कूल के जाके एक बच्चा आया था वहाँ से बेटर में, उसको रात 12 बजे से एंट्री किया था, 12 बजे से उसका ऑपरेट किया। ये कोई मतलब ये चीज नहीं है। मैंने अपने आर्टिकल में लिखा है, गवर्नमेंट को लिखूंगा ये साथ 3 बजे करेंगे 4 बजे का, ये उसकी माँ रो रही थी और लिटरली मैं खुद भी रोता था। मैं अपने बच्चे को देखा और मैंने लिखा नहीं। तो जन्नत होगा कि हम बड़े करीब हैं डॉक्टर, आप आगे इसकी जो मर्जी है।
सर मैं डॉक्टर आसमान कहना जस्ट 2 मिनट्स। सर आपने बड़ी ऑप्थेल्मोलॉजिस्ट के और सर मैं बड़ी चीजें कर रहा हूँ।
लेकिन मुझे वो दुख होता है कि जब मैं वो आरोपी के बच्चे जिनको आरोपी नहीं है उनको इंजेक्शन और लेजर लग रहे हैं, यार इंजेक्शन के पैसों का इशू नहीं है, लाख रुपए का इशू नहीं है।
I think that's a criminal thing to do, sir, I guess.
बीमारी है ही नहीं। आप यहाँ सोच सकते हो कि मेरा पोता मतलब मेरे भतीजे का बेटा 26 पे पैदा हुआ, मैंने खुद एग्जामिन नहीं किया, मैंने लाहौर में 3 लीडिंग आरोपी को भेजा, उनसे किसी को नाम नहीं बताना, तुमने एग्जामिन करवाने। ये मैं सच बता रहा हूँ, none of them examined under anesthesia and all of the 3 they asked for intravitreal anti-angiotic was stage 2 आरोपी। वो बच्चा आज 9 माह का हो गया है, एक लेजर एक इंजेक्शन। तो I have the evidence of my own grandson।
सर के सर आप माशाल्लाह काफी सीनियर लोग इधर बैठे हुए हैं। कैन आई जस्ट ब्रिंग इनटू योर नोटिस के हमने इधर ऑप्थेल्मोलॉजिस्ट की बात की है। In the UK, the ROP screening comes under the NICU team, the neonatologist, not the ophthalmologist. और पाकिस्तान में मेरे पिछले 3-4 महीनों का एक्सपीरियंस ये है कि मैं न्यूरोटोलॉजिस्ट के पास जाके मिन्नतें करता हूँ कि खुदा का वास्ता पेशेंट भेजो, और दे डोंट नो द ROP, दिस इज द बेस लाइन, ठीक है, वो लेट अलोन कि वो रेफर करें कि ना करें। तो एज ए OSP, being a general secretary and all the senior people around, do you not think कि हमारे कॉलेज को न्यूरोटोलॉजी जो कॉलेज है उससे डिस्कशन करनी चाहिए, या हम एज एन ऑप्थेल्मोलॉजिस्ट जाके उनकी कॉन्फ्रेंस के अंदर वी कैन टीच देम, यार दिस इज समथिंग दैट नीड्स टू बी रिफर्ड टू अस।
सारे न्यूरोलॉजिस्ट कितना हॉस्पिटल के इकट्ठे हुए, NGH के इकट्ठे हुए, एक्चुअली मुझे इशू ये है कि एवरीवन इज कंसर्न्ड अबाउट हिम और हिज पेशेंट। वो आगे का पॉसिबल नहीं है क्योंकि कोई खुद से ला नहीं है। ला ये होना चाहिए कि न्यूरोलॉजिस्ट के पास बच्चा पैदा हुआ है, उसने अगर रेफर नहीं किया ऑप्थेल्मोलॉजिस्ट को या पीडियाट्रिक ऑप्थेल्मोलॉजिस्ट को, अगर उसको 8 महीने बाद ROP होती है तो उस न्यूरोलॉजिस्ट को कोर्ट में सू होना चाहिए। ये कानून बनाओ। मैं वो क्यों नहीं करता? मेरे पास पेशेंट आता है 1.5 साल का ट्रीटमेंट, दोनों रेटिनल लेंस के साथ जुड़े हुए हैं, मां कहती है बैठा फोन से साढ़े आते थी या आधे आते थे, मेरे आंख में क्या है कि कहाँ पैदा हो, अच्छे भले महंगे टर्शरी केयर हॉस्पिटल प्राइवेट में पैदा। डॉक्टर ने उन्होंने दसा होना तो क्या जे दी जान दे बारे सोचो और किसी बारे नहीं सोच सकते।
मेरे पास मेरे मुंह से रस्ते से निकल गया कि आपको क्या कहा नहीं, उसको मेरा वो they were very well off patients और कोई लॉयर वगैरह थे जो टू साइड हॉस्पिटल, और मेरे पास I cannot tell you the number of phone calls I got that I should write a report that is and I have the number and I said you get it done by someone else, I will not do, and they quoted that.
न्यूरोलॉजिस्ट को आप नहीं समझा सकते अंटिल अनलेस से पूछने वाला। सारे लाहौर के न्यूरोलॉजिस्ट को पता है कि ROP की ग्रुप है, उन्होंने सबके साथ मीटिंग की।
So should we give up then, sir?
आप बच्चों के कैंप जाके करें, उसमें जो है ना 40 बच्चे हैं डालते तो वो टीचर भी नहीं कराया ना, इसको लिखा गवर्नमेंट को 11 से 4 नहीं लाती मुखार गुलाम बस उसको कंटिन्यू नहीं किया।
जब तक न्यूरोलॉजिस्ट ये नहीं सोचेगा कि बच्चे की जान से जितनी इम्पोर्टेंट जो है वो बच्चे की आंखें हैं, तब तक रेफर नहीं होगा या जब तक उससे कोई नहीं गुजरे। थैंक यू सो मच
सर। जस्ट लास्ट जो आखिरी व्हाट्सएप का मैसेज था, इट वाज फ्रॉम अ न्यूरोलॉजिस्ट, उसके बच्चे को ये मसला हुआ अनफॉर्चुनेटली। थैंक यू वेरी मच सर।
थैंक यू वेरी मच। एक अच्छी हीटेड डिस्कशन जनरेट हुई और इन एकेडमिक फोरम्स का बेसिकली ऑब्जेक्टिव भी यही है कि हम लोग एक एकेडमिक डिस्कशन जनरेट करें और उसके बाद उसके ऊपर डिस्कशन हो। बिफोर आई हैंड ओवर द पोडियम बैक टू डॉक्टर खाकान, आई वुड लाइक टू से अ फ्यू वर्ड्स फॉर माय जूनियर स्पेशली, क्योंकि ये हम 14 अगस्त भी कल साथ मना रहे हैं और आज अभी थोड़ी देर बाद हम केक कटिंग भी करेंगे, तो उसके हवाले से एक छोटी सी बात कहना चाहूँगी कि मीरे कारवां हम हैं, रूहे कारवां तुम थे, हम तो सिर्फ उनवां हैं, असल दास्तां तुम हो, नफरतों के दरवाजे खुद पे बंद ही रखना, इस वतन के परचम को सरबुलंद ही रखना। तो जो हम सब नफरतों की बात कर रहे हैं, प्लीज वी हैव टू कीप दैट एट बैक ऑफ आवर माइंड। हम प्रोग्रेसिव बात करें, सोल्यूशन की तरफ आए। प्रॉब्लम हम सबको पता है, बहुत देर से पता है, इसके सोल्यूशन डिवाइस करें और उसको इम्प्लीमेंट करें। थैंक यू सो वेरी मच।
Thank you. Now we come to the second last part of our clinical meeting. That's about the resident presentation and who has got. This is a competition. Competition should be always very healthy. Competition को हमेशा इसी तरह ये आज मेरा नहीं तो अगली दफा मेरा होगा, ठीक है? तो we have the result from our judges. So I will announce the result and. Our winner of today's
President company. So let it be the first one. So it's Dr. Komal Parekh. Dr. Komal Parekh is the first. I request Professor Seema to come and join me here. Professor Seema, please. Gupta, welcome. So So OSP has started a new tradition that we are giving a fountain pen to the residents. So this is the fountain pen for you. So now I will announce for the second position order is that Dr. Anoshia Jabil. Dr. Anoshia, please. And we have third position holder, Dr. Madiha Minhas. Dr. Madiha, please. And now I will request Seema Kayoon. She is the certificate for our guest speaker, and our guest speaker is Dr. Amjad. Now I will request our sponsor, Adia Community as well. Do we have a representative? पंद्रह बार उन्होंने हमें स्पॉन्सर किया आज की क्रिटिकल मीटिंग में फिर मैं नहीं बनाऊंगा Now Mr. Prasma joined me here and she done the wonderful job. She was a bit stressed and anxious, but she has done everything up to the mark. Thank you so much. So now this is a certificate for Dr. Rehana. You can just send her the copy from the society. And now we have come to the section, and we have one more step that we are arranging the cake cutting ceremony for the event of 14 seconds. So everyone come over the stage. छोटे बच्चे सब आज स्टेज पे आगे आ रहे हैं ये भी तो पीछे हमारी आप लोग आगे ऊपर स्टेज पे आज मैडम आज इसको ऊपर आगे करना ऊपर आगे करना बेटा ये पकड़ो
सर ये हमारा चीफ गेस्ट भी आ गया केक काटने के लिए इसकी प्रोसेस वाली
अस्सलाम वालेकुम जी वेरी गुड बेटा ये पेमेंट आ जाओ बेटा आप आ जाओ प्लीज आए आप सब लोग आ जाए आप आ जाए बंद कर दी